Dear colleagues and friends, good morning, afternoon, evening, wherever you are in the world. Welcome to this International Fetal Cardiology web course, which is divided in two parts. One running now for a couple of hours and one next Wednesday at the same time in agreement with your time lag that you have in your country. This international course has been organized by the Preis International School based in Florence, the Wayne State University Medical School based in Detroit, and the Summer Institute based in Perugia, Italy. And I'm very happy that to this course have agreed to give a presentation some of the most expert ultrasonologists and maternal fetal medicine specialists that are internationally renowned. With me is chairing this part, Professor Giuseppe Rizzo from Rome. We will share the introduction of different speakers, and then we run a final discussion that is open to everybody with a question that you post on the question answer that you find in your screen. I would like to acknowledge that this course has been also the opportunity to introduce some of the new tools that we have in the ultrasound arena, already introduced a few years ago, particularly the FINE. We will hear about either today, either Wednesday. The FINE, which was a development by the perinatal research branch of Wayne State University from Professor Lamy Yeo, Professor Roberto Romero, and Gustavo Abella, which will be speaking today, and other tools that you have the opportunity to see developed in the sense that to study the fetal heart by ultrasound is a very difficult task, apparently at the beginning. But nowadays, we have many tools that may facilitate this. And we will hear in these two sections of this cardiology web course. So without waiting too much time, I would like to introduce the first speaker, which is Professor Graziano Clerici, which is based in Perugia. He is a maternal fetal medicine specialist and is running the center, European Center for Medical Research and the International School of Ultrasound, Aesthetic and Ecology based in Italy, in Perugia, and he has taught to many student residents how to scan ultrasound for the last, I think, 30 years. So he is particularly indicated as an expert to start dealing with how to start examination of fetal heart, and of course, standard planes are one of the basic things that you should know. Graziano, thank you to be with us, and to you, the podium.
Thank you very much. Good morning or good afternoon, depending on your geographical position. I would like to start my presentation by briefly thanking the organizers of this important course, and particularly Professor Giancarlo Di Renzo, with whom I shared all my professional life, and Professor Roberto Romero, who kindly hosted me to work with this group many years ago in Detroit. I thank them for choosing me to give my contribution with the extraordinary colleagues who have inspired me and who still inspire all of us in the wonderful field of prenatal diagnosis, such as Gregory DeVore, Rabbi Chawi, Giuseppe Rizzo, etc. It is a great honor for me to take part of this event with so great experts. Thank you again for this wonderful opportunity. And now I will start my presentation by focusing on the methodological aspect on how to obtain the main scanning planes for the evaluation of fetal heart. I don't know if you can see my my screen. Can you see my screen? Okay.
Yes, now it's opening. Okay. Yes.
Okay. So before starting the examination of the fetal heart, I want to share with you some preliminary consideration. And particularly, I suggest, before starting the evaluation of the fetal heart, to choose an appropriate preset of the equipment and try to improve it when you are confident with the machine. We have to recognize the fetal line and position, evaluate the position of the placenta under the fetal spine. If necessary, try to obtain or improve the acoustic window, particularly try to avoid the shoulder, arms, spine, and ribs shadow. Try to obtain, when possible, both apical and transverse view of the fetal heart. I will show you the reason why I am underlining this aspect. And try to obtain as much as possible the main scanning planes that you are seeing here, the four-chamber view, left and right outflow tract, the three-vessel and trachea view, the arches, aortic and ductal arch, and the vena cava view. To help you in the evaluation of fetal heart, I want to show you a technique, a very simple technique that I call the shoulder technique, that can help you in avoiding the shoulder, arms, spine, and ribs shadow. As you can see here, the preliminary aspect is to look at the alignment between the head and the body of the fetus. They should be in the same position in order to avoid some traumatic event for the fetus. When you are sure that the head and the body are in the same position, you can engage, pushing your probe, the achievable shoulder, and try to push, rotating, and try to rotate the body of the fetus. I will show you here the technique. Sometimes it's very easy. I'm checking the alignment between the head and the body. I engaging the shoulder and the pushing. As you can see, in this way, it's possible to change, to rotate the body of the fetus and to have a very good view of the fetal heart. Not every time it's so easy, but it is possible, and I suggest to try to apply this technique every day in your clinical practice. So before starting in evaluating the main scanning plane for the fetal heart, I want to suggest that we have to start for the examination of the upper abdomen. Remember to evaluate this part of the fetus and the position of the abdominal organs, and then the correspondence with the left and right side of the heart. So the left of the heart should be in correspondence with the right side of the organs in the abdomen, and the same for the left side. This is very important in some cases of isomerism in order to make the diagnosis of the challenging situations. So you can see here the main scanning planes that we can evaluate after the evaluation of the upper abdomen. The most important, all of you know, that is the four-chamber view. But as I will show you, we need to evaluate other scanning planes that are very important. The left and right outflow tract, the three-vessel and trachea view, the ductal arch, the aortic arch, and the vena cava view. And I will show you the methodology to get this different scanning plane. As I told you before, when you are scanning the fetal heart, when possible, it is very good to obtain the perpendicular and the apical view of the heart. Why? Because you know that the longitudinal resolution, the ultrasound, are greater than the lateral resolution. So in transverse view, for example, you will see very clearly the septa, the intraventricular septum, the atrial septum, the lateral wall of the heart, but you can't see very clearly, for example, the atrioventricular valves. You can see very clearly here the septa, and also in this perpendicular insonation, you can see very clearly also the moderator band. That is very important for the identification of the right ventricle. Here you can see underlined the heart cavity. So in apical position, longitudinal, as you can see here, it's very clearly evident the apical portion of the wall, the heart, the atrioventricular valves, and the wall of the atria. In this view is visible very clearly the two inferior pulmonary veins that are going into the left atrium, and you can see very clearly the atrioventricular valves, the mitral and tricuspid valve. So when we are able to obtain the four-chamber view, what we have to look for? This list of points are very important, and we have to look every time to all of these points. We have to look that the heart is to the left of the chest with the apex pointing at about 45 degrees forward and to the left of the chest. The heart is above the diaphragm, and there are no other abnormal structures in the chest, for example, the stomach. The area occupied by the heart is about a third of that of the thorax. Both ventricle and the atria are present, they have approximately equal size. The ventricle occupies the apex, the left ventricle occupies the apex of the heart, like you can see here. The moderator band is visible toward the apex of the right ventricle, and these two last aspects that are very important in order to identify the left ventricle and the right ventricle. The intraventricular and intraatrial septa are present and they appear intact. The atrioventricular valves are present and they appear normal, with a slight displacement of the medial edge of the tricuspid valve toward the apex. You have to see the present disposition of the pulmonary veins, particularly, as I told you, in this kind of view, in the longitudinal view. And you have to check if there is no pericardial pleural effusion. That sometimes is a sign of heart anomalies, but also in general or fetal pathology. In the last point, you can see I put the present regularity and position of the coronary sinus. Why? Because I think it's easy to get, it's easy to evaluate, and can help you in the identification of the left side of the heart in some cases of isomerism. I will show you in this short single loop all the aspects that I showed you before. You can see here the coronary sinus going to the right atrium, very close to the mitral valve, identifying the left side of the heart. You can see the atrioventricular valves, as I told you, with a slight displacement of the medial edge, the tricuspid valve toward the apex. You can see the ventricles that have approximately equal size, with the left ventricle forming the apex and the right ventricle under the sternum with a moderator band. Now you can see the atria that have approximately equal size, with the foramen ovale and the septum primum freely floating into the left atrium. You can see the two posterior inferior pulmonary veins very close to the descending aorta, very close to the left atrium. So you can see that many fetal heart abnormalities are diagnosable in the four-chamber view, and the main ones are the ectopia cordis, cardiac dislocations, ventricular hypoplasia, single ventricles, cardiomegaly and or hypertrophy, large intraatrial or intraventricular defects, valvular pathologies, Epstein anomaly, cardiac tumors, anomalous pulmonary venous return, particularly in the apical view, and it is possible to see the pericardial pleural effusion. But you can see here many pathologies, sometimes very challenging, are not diagnosable in the four-chamber view, and this aspect pushes us in the evaluation of the scanning plane of the fetal heart. The main ones that are not diagnosable in the four-chamber view are the tetralogy of Fallot, the transposition of great arteries, truncus arteriosus, the double outlet ventricles, left and right, the stenosis, atresia of the aortic or of the pulmonary valve, and some pathology of the aortic arch, like coarctation, interruption, right aortic arch or double aortic arch, and so on. So these pathologies, as you can see, represent a real challenge in prenatal diagnosis. Why? Because they are difficult to diagnose before birth, and particularly they are not diagnosable in the four-chamber view. They are correctable after birth. Their diagnosis is crucial in choosing site, time, and mode of delivery. So their diagnosis is crucial for prognostic and medical legal issues, as you can understand. So starting the examination of the fetal heart, I want to give you this message. Keep in mind this very simple movement. Tilt the transducer from the four-chamber view toward the fetal head. In this way, you can get all the main scanning plane of the fetal heart. And in the meantime, when you tilt the transducer, you have to rotate a little bit to the right or to the left shoulder, and you will get the outflow tracts scanning plane and also the trivessel and trachea view. I will show you the methodology. Looking at the left outflow tract, how we can get, starting from the four-chamber view that all of us are able to obtain, you can see in red the ultrasound beam that is parallel to the diaphragm, because the position of the heart in the fetus is horizontal. So you have to maintain the probe in this alignment, and from this position you have to tilt the transducer, look at the ultrasound beam toward the fetal head, and slightly rotate to the right shoulder. This is the way to get the left outflow tract. Keep in mind these two images. Here you can see the movement of the probe, tilt and rotate to the right shoulder. In this way, you will get the left outflow tract. You can see, you can check the continuity between the intraventricular septum and the ascending aorta. You can see the appearance of the aortic valve during diastole, the mitral valve that is opening now, and during systole, the mitral valve is closing and the aortic valve is opening. So with this simple movement, very thin movement, you can get the left outflow tract. What about the right outflow tract? From the same position, because we know how to get the four-chamber view, you can see here we have to tilt the transducer a little bit more than before for the left outflow tract, but in this case we have to rotate a little bit the ultrasound beam to the left shoulder. I will show you here the movement. You see, tilt the transducer or the fetal head, and in this case rotate on the other side. You see here, to the right shoulder of the fetus. And here you can see very clearly the right outflow tract, the right ventricle, the pulmonary valve, the main pulmonary artery, the right branch of the pulmonary arteries and the ductus venosus here, very close to the descending aorta. So here you can see the scheme of action in getting the left and right outflow tract. Tilt the transducer, rotate to the right shoulder, you will get the left outflow tract. Tilt a little bit more and rotate to the left shoulder in order to get the right outflow tract. So now we are able to obtain the left and the right outflow tract. But what we have to look for? We have to look to this aspect. We have to recognize all these aspects, and particularly that the aorta arises from the left ventricle and the pulmonary artery from the right ventricle. We have to look and to evaluate the disposition of the vessels, and we have to recognize that they are crossing vessels. As you can see here, the ascending aorta is going up and the pulmonary artery is going down. We have to look at alignment, particularly in the left outflow tract, in order to see the continuity between the intraventricular septum and the ascending aorta, to exclude some intraventricular septal defects. We have to look into the sides of these two vessels that have approximately equal size, with the little predominance of the pulmonary artery, with a ratio about 1.2 to 1. We have to see the continuity of the vessel and the number. No additional vessel, no less vessels than normal. Here you can see the methodology to get the 3-vessel and trachea view. And as you can see here, I suggest to start from the right outflow tract, because now we are able to get the right outflow tract. So starting from this scanning plane, you can see you have to tilt the transducer a little bit more, increase the inclination toward the fetal head, but you have to reduce a little bit the rotation to the left shoulder. You can see here, look at the hand and the probe movement, starting from the right outflow tract. You have to push a little bit more and to tilt a little bit more toward the fetal head and reduce very slightly the rotation, as you can see here. This way, you can get the 3-vessel and trachea view. You can see here the pulmonary artery, the aorta, the superior vena cava, and the trachea. Here is the scheme of action in getting the 3-vessel and trachea view. Starting from the right outflow tract, you can see here the ultrasound beam, tilt a little bit more and reduce the rotation to the left shoulder. So now we are able to get the 3-vessel and trachea view, and it is time to say what we have to look for. We have to look the number of the vessel, the disposition of the vessel with the pulmonary trunk, ductus arteriosus, and the aorta with the isthmus, line to the left of the chest with the trachea and the superior vena cava to the right. The dimension and appearance of the vessels with, as I told you, a little predominance of the pulmonary trunk to the aorta with a ratio of 1.2 to 1, and using color, because as probably will come out from the other lecture this year and Wednesday, we have to use color in order to see the direction of the flow. That should be the same. I'm closing in showing you how to get all this scanning plane. Tilting, rotating to the left, tilting, rotating to the right, tilting a little bit more to get the 3-vessel and trachea view. I will finish my presentation with a scheme of action in getting the aortic arch and the ductal arch. As you can see here, from the three-vessel trachea view, I suggest to start from this scanning plane. You have to make the alignment with the pulmonary artery. And when you are in this position, you have to turn the transducer on 90 degrees. You will get the aortic arch. In the same way, you can get the aortic arch, making the alignment, going a little bit more laterally to the right shoulder with the aorta. In this way, when you are in this situation, you can turn the transducer and will obtain the aortic arch. Finally, I will show you the methodology to get the vena cava view. And I suggest to start from the aortic arch. You can see here in the three-vessel and trachea view, the superior vena cava is very close and to the right of the ascending aorta. So you have to move the transducer laterally to the right shoulder. And when you are with an alignment with this situation, you have to go laterally in order to see the venous return into the right atrium. So thank you very much for your attention. I am very proud to be part of this important meeting, and I'm ready for any question. Thank you again.
Thank you very much, Graziano.
I hope to be in time.
You make easy something that is so difficult at the beginning, but I think that with the schema that you show, the people are already introduced very well to this, difficult examination of fetal heart. As I said, the question will be at the end. You can write the question in the question and answer panel that you have. And we move to the second presenter, which is Dr. Gustavo Abella. Gustavo Abella is from Ecuador, but he lives in the United States. He's a computer scientist. He's inventor of several, applications for ultrasound machine. He's president and CEO of the MÉCH platform based in New York. He's a passionate in introducing this kind of methodology in our arena. And I will invite also, and just to remind you that also next Monday, we have another course which will be dedicated to simulation. And also this course, the simulation tool has been introduced by Gustavo. I would like also to remind that Gustavo now will introduce this methodology, and methodology will help many of us and of you to navigate in the fetal heart and to try to understand what Dr. Clerici has show you that may be complicated at the beginning. The system is called FIND, Fetal Intelligence Navigation Echocardiography. As I said, you may have some channel in YouTube run by Lamier, and you can may look more deeply about this, but I ask Gustavo to introduce this model and to give his presentation now. Thank you very much, Gustavo, to be with us.
Thank you, Dr. Di Renzo. Before starting, I would like to say, Professor Clerici, that I am very, very much impressed by your presentation, because you pointed out the necessity to try to obtain a posterior spine positioning on the fetus. And we strongly believe that this is of extreme importance for fetal echo. So sometimes the lateral approach could make impossible the arches, and the exclusion of the arches is like blinding the eye for echo diagnosis. So I really believe that what you are showing that looks simple, it's the way to go. So now I will start with my presentation. Can I share my screen? Okay. Good. Is my screen
Yes,
visible?
yeah, we can see it. It's okay. Go ahead.
Okay, very good. Let me get rid of this panel. Okay. So I am pleased to introduce, welcome everyone in all the regions you are. I am pleased to present this afternoon for me the Fetal Intelligent Navigation Echocardiography technology known as FINE. This was developed over 4 years of hard work at Perinatology Research Branch by several scientists like Professor Lamillot, Professor Roberto Romero, and there's some engineers like Ricardo Guilloso and myself. So the basic concept about FINE is to obtain planes with high accuracy in a, let's say, in an automatic way. That's the purpose. So the heart, as is expressed here, is the most difficult organ to study. So you can see in this image that were obtained from Professor Philippe Gentil. The heart is very difficult to evaluate because of the intrinsic angling of planes within it, and the fact that it could be positioned in many inconvenient fetal presentations. So to manage the navigation with slicing into D pose a challenge for the sonographer. So basically, the main purpose of FINE is the automatic retrieval of the planes, these being normal or even abnormal planes. So this template that you can see here is displaying the sequence of images that were shown before, and including the arches. So this is the goal to obtain with FINE. So it's a diagnostic tool that will deliver 9 standard planes, including the arches. But the most important thing is the accuracy, the intrinsic accuracy of 98%, based on a single volume scan, meaning that the sonographer acquired the volume, a stick, and it's converted to this display. These planes are required by several societies like AIUM, American Heart Association, and more. So now, this schematic is showing how complex the planes are. So look, those are the longitudinals, and these are the transverses. So actually, they are very unlikely parallel. They are not parallel. Each one of them, they require certain tilting that of course the sonographers will learn after several years of practice. So this is the reason why the fetal echo is like a nightmare to do. And if you on top rotate the fetus to an inconvenient presentation like anterior spine, lateral spine, this can be very, very hard to do. So a FINE is available to physicians in a commercial product. I'm not trying to promote any marketing product here, but I just want to express that this is available for physicians. Samsung incorporated this and changed the name to 5D Heart. It's a trademark belonging to Samsung that is denominated in order to express the FINE method implemented in their machines. In this case, we can see that the Samsung flagship model, the Era W10, it has the FINE method or 5D Heart. Thousands of 5D Heart units are already functional in the world, are deployed in the world over several years. So the system is very well adapted. So this is a display of the 9 planes that are delivered by FINE. You can see the 3-vessel and trachea view, 4-chamber view, this one, 5-chamber view, LVOT, left ventricular outflow tract, right ventricular outflow tract, this one. The abdomen view, the abdomen is, the stomach is shown here. The lack of image here is because of the stick aperture that depends on the angling that the sonographer sets. The ductal arch, the aortic arch, and finally the cava view, vena cava. So the interesting thing of watching this display is that you can correlate in real time the exact same phase on each plane. And that could be interesting in terms of evaluating the heart. The most, let's say, important thing is the accuracy of 98%, meaning that you can rely on these planes. This is very important when you are trying to prove that your suspicion is right. This was published by Professor Romero and his team from PRB. There are several publications available on fine method during these years. The PRB from China, Brazil, Italy, and several more from different places, Germany, the Charité, and other institutions. So what they publish is the reproducibility, the sensitivity, the interoperator, let's say, efficacy, and those kind of publications, including the ability to display the proper planes when the fetus has congenital heart defects. So why are we thinking in making a fine method? Why? What's the reason for this tool? It's because it is crucial to improve sensitivity and specificity. This was published by Professor Roberto Romero in 2013. So you can see that to this sensitivity, depending the author, can be somewhere between 15 to 39%. Of course, in certain places, these values are much higher, but in general practitioners could be lower. So this is a problem. This is a real problem, because if we do not have sensitivity, then there is no way to get a diagnosis. So how can we cope with this problem? One way is to add more standard planes. So societies have been recommending a set of planes during the years in order to cope with this problem. So it was at the beginning, it was just for chamber view, but we have clearly see that the for chamber view could not be enough for certain pathologies, like nephrology, for example. Then the 3-vessel view was added in 2003 it was known as the ISUOC Basic. Then afterwards, they added more planes, so they extended the view, so they added the outflow tracts. And then this was published by ISUOC. So later on, 2010, the American Heart Association and the AIUM, they added all these views, the arches, basically. So including the biventricular view. So these are more sophisticated planes and probably are intended for specificity rather than sensitivity. So if you go to the AIUM, you will see the planes that they recommend. So in 2015, we developed the first version. Now we have like 7 generations of fine, where we added all these views, including some navigations that are outside the 9 planes. So the idea was to replicate the request from AIUM. The purpose of this is to increase the sensitivity. So if you apply all these views, your sensitivity is much higher. So we could define that there is a screening phase and there is a diagnostic phase. So when you are screening, you need to use the 2D screening that is recommended by societies, meaning that the tracts, the flow tracts, the 3-vessel view, 4-chamber view, and the stomach. Those are the planes that you need to get, okay? Because the purpose is to find suspicious morphology. But if you are in the diagnostic phase, you need to actually add all these views, including other measurements, probably color, and the purpose of 5D heart in this case for diagnosis is not for screening. The purpose of 5D heart is to confirm what you are finding in 2D. So we believe that 2D is the gold standard and must be applied always. 2D is the tool to be used. But if there is suspicion, if there is a finding, then 5D heart is very valuable information. It's like your own second opinion. So the clinical purpose for 5D heart, it is recommended once the screening gets a suspicion. So you could use as a screening device, but in terms of workflow, it's not very convenient. You need to get a stick, you need to position the patient, you have to mark some points. So we believe that this tool is an excellent aid when the suspicion is gotten. So it's a complement to the diagnosis, an in-house second opinion that increase the confidence of your findings, and in some case may help refining the diagnosis. And I think on the 28th, several doctors that are very knowledgeable on this technology will describe some kind of, let's say, of changing the mind based on the images shown by Fine afterwards for a given diagnosis. So this paper was coming from PRB, okay, in 2018, and this paper was important because it was not focused on the let's say on the accuracy of the plane, but in order to see if congenital heart disease fetuses can be evaluated with this automatic tool, in order to see if those planes are reflecting the pathology. So looks like it went well. So how this works, I will quickly show this illustration where you will understand the process. So for the heart stick is a pumping heart that changes the shape during the cardiac cycle. So we find protodiastole and protosystole. In protodiastole or protosystole, what you will see is that the valves will be opened and closed accordingly. So when the motor of the probe is acquiring the stick, it goes across all the possible anatomy. That's called the stick. But the heart can be in many presentations, so not necessarily will always be the perfect presentation. So what you do, the operator do, is to do a click. Those yellow balls are representing the click, like the aorta at the stomach. That's a first marker. These biomarkers, like the aorta and 4-chamber view, define a line that is the axis. So now the computer knows how to put the heart vertical. Now you can do the same thing with the crux of the heart that is touching the aortic valve. That's a crux. And now based on that, you can continue with other important marks. And you see that our points are going in different elevation of the heart. why are we doing this? Why are we in our invention? Why are we marking the superior vena cava and we are marking the transverse aortic arch? Because this elevation is allowing us to identify this very specific heart that will not be repeated in other baby. It's a unique fingerprint of the heart. So now the computer will start doing some analysis on those points and create, based on these 7 points, additional second landmarks that will use a decision tree logic that is internal. So it's like saying, is the stomach at the left? Yes, no, flip. So it will do all these decisions. That's the reason why this is called intelligent navigation. So the primary landmarks made by the user are generating a model, and this geometric model is what we are using to obtain the planes. We are not dissecting the heart, we are dissecting the model. So we are not dependent on the image quality. So, but the planes have 98% of accuracy. The reason is because we are using a model that is adaptive to that fetus. That could be normal, abnormal, distorted, it doesn't matter. The planes will be obtained. Okay, this slice represents one of the different planes that you can get. Okay. Now, how I am in time?
You are perfect, Gustavo. Thank you very much for your presentation. It was really great, and you.
I think, Giuseppe, that he has to show something.
Yes, I would like to
just
show
a few minutes. Yeah,
yes,
Okay.
like 3 minutes, please.
Go ahead, go ahead.
Go ahead.
Can you see my screen now?
Yeah.
Can you see my screen?
Yes.
Okay, so I will use a simulator that we will show later on. We developed this simulator that is called the Opus, just to train people on how to do 2D and fine. So this is a heart. I'm scanning the heart with this probe. This is a convex probe. Okay, I'm scanning. So you can see what Professor Graciano was showing us about the angling, starting from the abdomen, going to the 4-chamber view, 5-chamber view, the 3-vessel view, and then the rotation. So you can go here to the LVOT, or you can go here, I'm sorry, RVOT, and then you can go here to the LVOT. So this is kind of okay, kind of easy, because the baby has spine down, which is the most convenient presentation. But if the baby is on the side, is flipped on the side, this could be very, very challenging. So how does fine work? So you go like this until you get the 4-chamber view. Once you get to the 4-chamber view, you click the 5D heart button. Okay, you acquire a stick. So now the stick is being acquired. Now I am virtually acquiring a stick right now. And now this is the fine interface. So you are looking to those planes that I showed you before in my presentation. So these are my 7 structures that are requested in this references image. So first of all, I need to go to the stomach. Okay, so this is the stomach. So I can mark the aorta at the stomach. So when I click, it jumps to the 4-chamber view automatically. And look, what's interesting is that the valves are closed. So the system has like an EKG that detects the valves and it will close, so you can clearly see the crux of the heart. So I'm marking this aorta. Now the predictive cursor takes me to the crux of the heart. Now I can see this green line that I need to align to the septum. Okay, now I need to mark the pulmonary valve. So where is the pulmonary valve? It could be a little bit more cranial. Okay, so this is what the operator does. So look, this is the pulmonary valve. You can see that it goes down in Y. Then I'm going to the superior vena cava, and finally I will mark in the 3-vessel view, I will mark the transverse aortic arch. This is what I do, and these are my images. Okay, so you can see here. You can see here all the planes that they look very nice. and they are automatically obtained. I can eliminate the color. I can go to the next view, chamber view, 5-chamber view. The pumping, the beating rate is adjustable to your taste. So this LVOT, RVOT. So this is a very sophisticated RVOT because it shows also the short axis of the great vessels. So you can compare the aortic valve with the pulmonary valve. That's the purpose of this one. Stomach, ductal arch, aortic arch, and caval view. So as now I've finished, thank you so much. I hope you enjoyed this little presentation. Next session, I will show how this works with real pathology. Thank you so much.
Gustavo, thank you again also for this small but very nice and impressive presentation. I feel that you give a lot of topics that we can discuss later. Also, I would like to thank Giancarlo for the opportunity to be here. For me, it's a great honor and pleasure to chair such an important session. And among the speakers, I very like to introduce Valentina Zivova. Most of you already well know. She's one of the members of the Preis School, but she also an extraordinary fetal surgeon in St. Petersburg in Russia. So please, Valentina, the podium is yours, and have a nice presentation.
Thank you for this nice introduction. Good afternoon for everybody. And I want to thank Professor Dirente and Wayne State University for organizing such important course. And for me, it's a big honor to speak, especially today, as a member of international school. And I'm going to speak today about evaluation of cardiac function. Okay. I hope.
Yes, it's okay, it's okay.
Mm-hmm.
Perfect.
Okay, being a maternal fetal specialist, I know how ultrasound diagnostics looks like. And when we find some anatomical abnormality, we have usually to determine what is exactly in order to proceed different scenario. But when we see that anatomically everything is normal, but in the same time we see that size of the heart is bigger, myocardium looks different than normal, we understand that something happened with cardiac function. So what we usually do? Some of us evaluate by themselves, but some of us, and this is a majority of prenatal diagnosis, sent to another consultation to the pediatric cardiologist or to the expert in this field. But I think you'll agree with me that in majority of these cases, this is a waste of time. And of course, this raises anxiety in a future mother and disappointed us when we couldn't determine what exactly happened with the fetus. But what if I tell you that you don't need to send for another consultation, you can answer for all burning questions by yourself, and finally to give a chance to the fetus. So how can we do it? We usually ask for additional options to have a machine, but everything what is needed, we basically have in machine already. So I suggest to use 3 types of ultrasound diagnosis dedicated to evaluation, motion, and flow, and to assess only 7 parameters. As a maternal fetal specialist, I have the same work issue. I have a lot of patients during the day and limit of time to scan each patient. And I want to share with you with some insights which we can proceed very easy, which will be useful and very fast in procedure. So let's start with the first is ventricle filling evaluation by pulse wave Doppler. To obtain this wave is very easy because all of us are trained to do evaluation of tricuspid regurgitation in the first trimester, and technique is the same. And we proceeded for both ventricles. Normally, we have to obtain a wave like you see in this slide with the two peaks, with the early phase of ventricle filling, which is formed by passive myocardial relaxation, and late phase, which is formed by atrial contraction. In normal heart, this ratio will be calculated by machine and will be less than 1. But also we can obtain pathological results, and there are two of them. When this ratio is higher than 1, that means that atrial contraction are decreased. This usually happened in cases of volume overload and monophasic wave, as you can see in a slide, one peak flow. This happened when volume overload cases are chronic or in congenital heart defects, for instance, like in aortic stenosis, when ventricle is damaged by fibrinolysis. The second one tells us about global function of the heart is the MPI index or TE index. And to obtain it, we have to get in one image, as you can see in the slide, diastole and systole. How we can do it? For instance, for left ventricle, we can do a 4-chamber view scan in order to receive mitral valve and aortic valve. And getting this, we calculate ejection time, and 2 is a volumic time contraction and relaxation, and machine automatically, according to the formula, will calculate this index. Important, dear colleagues, that these advantages of this parameter that is independent of geometry remodeling, is independent of higher heartbeat, and also if is presented regurgitation. I want to draw attention of you that is not needed to calculate when we see a big heart or we see that is completely damaged myocardium. This is obvious that there are cardiac dysfunction. It's important to calculate in a group of the pregnancy who have high risk of developed cardiac dysfunction. And in cases like a monochorionic twins, we can see before changes in MPI, before we will see visual signs, before we will see hypertrophy. Also in gestational diabetes is very tricky to find when is a cardiac dysfunction and before will damaged myocardium. Third parameter is to evaluate relaxation and contraction velocity. And tissue motion signals has a low velocity and higher amplitude. To obtain this parameter, we have to perform 4-chamber view, as you can see in this video, when apex is at 12 o'clock or at 6 o'clock, because ultrasound beam should go parallel. We place control in lateral to annulus and obtain this wave, as you can see in this slide. We calculate early, late velocity, and output velocity of the myocardium. These tests tell us about longitudinal motions. As well as ventricular filling, we have to calculate E prime to A prime ratio. And normally, in normal heart, it looks like in this part of the slide. This is abnormal. And it's very useful method to calculate in complications which lead to hypertrophy. Of course, there are some limitations of this method. First is angle dependent, and third trimester is quite difficult to obtain a right position. And also when is higher heartbeat, we can see a fusion of the waves, and this also don't help us. Okay, we pass almost half of the parameters, and this parameter, fourth parameter, E to E prime ratio, doesn't require to do anything, because if you calculate previous two, this one will appear in your report automatically. What is this parameter? This is representative of diastolic function, because it shows in meantime how is myocardium is going myocardium relaxation, and in meantime how react the annulus of the valve. And during gestational age, this parameter decrease. Why? Because in the early weeks of pregnancy, we have completely immature myocardial and with increasing maturation, with increasing relaxation and contractility and biometrical growth, this parameter will decrease. Usually, I use this parameter when I evaluate congenital heart disease, especially with systemic ventricle, because we are used to think that systemic ventricle takes off function of the heart of itself, but also it can present a diastolic dysfunction. For instance, in a hypoplastic left heart syndrome, when there are left ventricle coronary cameral connection, this affect redistribution of the blood to health right ventricle and lead to geometry remodeling of the right ventricle. But this is a crucial when we discuss about prognosis after operation, and usually we perform when we scan with congenital heart disease. The fifth one is done by MMOD. This parameter is TAPSI and MAPSI. And MMOD we usually use in early weeks of pregnancy when we try to catch first heartbeat of the embryo, because it's much more sensitive than pulse wave Doppler. And also we use when it's in cases with arrhythmia. But this parameter is very good to evaluate endocardial longitudinal fibers because they are very sensitive under hypoxia and their first damage after volume overload. And calculating this amplitude of maximal displacement of atrioventricular rings will tell us a lot about systolic function of the heart. These parameters increase with gestational age and also correlate with estimated weight of the fetus, and is crucial to evaluate in cases when there are high risk of development cardiac dysfunction, especially if you have some doubts in cases with maternal diabetes or in a management of fetal growth restriction, when there are a lot of questions how long to prolong this pregnancy, when to deliver, and of course in structural cardiac anomalies and in monochorionic twins. Of course, this method has some limitation, is also angle dependent, but in modern machine, we have a lot of tools, especially electric stick, which help us to overcome this limitation, because you can also proceed with retrospective, you can change position of the sample without thinking about position of the fetus. Sixth parameter is pulmonary vein assessment, and to obtain it, we have to adjust in vena atrial position. Usually we scan right superior pulmonary vein, and of course guided by color flow Doppler. And I suggest using it in stratifying risk of congenital heart disease with highly restrictive intact atrial septum, because this is a cause of the left atrium and pulmonary vein hypertension. And this effect has an adverse effect of developing lung and pulmonary vasculature. After birth, these neonates lack oxygenated blood, which from the pulmonary vein to systemic circulation. And this lead for hypoxia and early death. Also, I use a pulmonary vein assessment when I choose a candidate for balloon valvuloplasty. The seventh and is last but not at least is a ductus venosus. I think everyone is familiar how to obtain a ductus venosus, but I want to focus everyone and to use it consciously and assessed through cardiac cycle, because through looking to ductus venosus, we can see all cardiac cycles. Normally, in the first image we can see two peaks. We see a systole, and after this systole should go slowly down to ventricular relaxation, after also slowly going to ventricle filling and atrial contraction. In the second and third, you see a pathological waves, and you see that systole and diastole became very sharp and short, and ventricular relaxation decreased and atrial contraction also or decreased or even reversed. And this tells us about systolic and diastolic dysfunction, about hypoxia, acidosis, and prenatal preterminal condition, and require fast decision. Okay, this was a boring theory part. Now let me show you a couple of examples in order to understand when it's important to evaluate cardiac function for making decision. The first is a fetal growth restriction, came to me at 30 weeks, completely without amniotic fluid, was angidramnion, was a severe fetal growth restriction. As you can see in this video, that size of the heart is big. We see that the apex is rotated. And we know that management of these pregnancies is very difficult. We don't know how long to keep in a pump. We don't know when to deliver and what will be the results. And in their nature, they have, because of high resistance of placenta vessels, they have a compensatory effect. They has vasodilatation of middle cerebral artery, and a coronary arteries dilated, which leads to remodeling ventricles and for geometry remodeling vessels. And in this case, evaluation of ventricle filling shows that right ventricle not possible to calculate EA ratio because we see a fusion of these waves, and MPI index was higher, and TAPSI and MAPSI show that is decreased, which tell us that is completely hypoxic. This case was delivered, weight was 880 grams, and despite operation of necrotizing enterocolitis, everything was recovered, and this girl was discharged after 3 months to home. The second one is a case who came at 33 weeks, completely hydropic, as you can see, with a skin edema, with the polyhydramnions. And evaluation of this case show us the ductus venosus was okay. Middle cerebral artery present very high velocity, which tell us that this fetus is anemic. And I'll show you in this video. I slow down the speed in order to careful evaluation of movements of the atrioventricular valve. You can see that for the first, you see that it's a little bit hypertrophic myocardium, but valve is going normally. What we can see is that atrium looks smaller than normal. And in fact, when we evaluate cardiac function, we see that atrium contraction are decreased. We see that EA ratio are higher for both ventricles, MPI indexes are high, and TAPSI-MAPSI was okay, which tells that systolic function was preserved. According to this information, if we will do a blood transfusion, which require anemia, this will be catastrophic for this fetus because it's already very difficult for this heart to pump a volume. And first what I did, I evacuate, I decompressed a thorax, and only after that, I perform a blood transfusion. And this case was delivered on term without any complication. It's healthy, good baby. The third example is example of fetus from monochorionic twins, which had been complicated by TTTS and operated 6 weeks before. And afterwards suggest our guidelines, just to perform evaluation of ductus venosus, of umbilical vessels, middle cerebral artery, and not cardiac evaluation. But look at this ductus venosus, looks normally, yes, but if we look to the heart, we see that also nothing can too much impress, a little bit of tricuspid regurgitation, slightly. Evaluating of cardiac function shows that there are dysfunctions, that EA ratio is higher. We can see in this wave that A peak is lower than E peak, MPI index is higher, but umbilical vessels and ductus was okay. Unfortunately, this case delivered 1 week after ultrasound diagnosis, which I show you, and hours after present a severe pulmonary stenosis. You see what hypertrophy here. This case underlines that fetus with a chronic heart wall stress can have more chance to face preterm birth issue, respiratory distress, and to increase in some hormonal answers, in some hormonal release, which will lead for developing this hypertrophy and moderate this severe pulmonary stenosis. We have to keep in mind that hemodynamic of the fetus depend not only for shunts, but also of biochemical factors, and also in this case, fetus has a chronic heart wall stress, which of course brings some issue for preterm birth and lead to formation of this pulmonary stenosis. In this case, I want to draw your attention that we have to evaluate cardiac function, not only peripheral vessels, but also cardiac function in case who has a high risk of developing cardiac dysfunction. This is a pregnancy-related complications, high-risk pregnancy, and congenital anomalies, which has altered cardiac output. In conclusion, I want to say that these 7 parameters are very easy to obtain and very fast to proceed, and serve us a lot to be 1 step ahead to save and to predict and to prevent these damages. This was the basic tools, dear colleagues. I think they will help in routine work. I can imagine which level of diagnostic we will reach when we will add some advanced programs. Thank you for your attention.
Thank you to you, Valentina. Very nice and complete presentation. You enter in the field of the functional assessment of the heart, which also, in my opinion, is really important, probably is the future of fetal medicine. Now is the time of Professor DeVore from the States. Unfortunately, he will be unable to connect directly for us, probably also for time now in California. Professor DeVore is one of the most famous experts in the fetal heart. He's director of the Fetal Echo Center in Los Angeles, and he is also professor at the University of California, Los Angeles. I guess that the MCA have a video recorded video, excellent. So we'll can see.
The title of this presentation is Spectral Tracking of the Fetal Heart from A to Z. T.S. Eliot was one of the 20th century's most gifted poets and writers. He was insightful and wrote the following: "We shall not cease from exploration, and the end of all our exploring will be to arrive where we started and know the place for the first time." This statement pertains to the historical journey of the four-chamber view. Our group has published over 16 peer-reviewed papers since 2015, regarding what I will share with you in the next few minutes. My colleagues who assisted me were two pediatric cardiologists, Dr. Mark Skolansky and Dr. Gary Seitu. A software consultant, Berthold Klaas from TomTech, was also instrumental in assisting me with the analysis of the raw data and creating the Excel spreadsheet to compute the measurements I will describe in this presentation, which are currently available on the GE Voluson system Fetal HQ. In 2016, I suggested to TomTech and GE Voluson team to work together and integrate the TomTech system in the E10 Voluson. The first meeting occurred in Iswag in Rome, Italy. The TomTech team provided the speckle tracking analysis software for the GE team to integrate this into their system and provided all of the measurements I will describe in this presentation with graphs, Z-scores, and centiles. The workflow developed by the GE engineers resulted in the user being able to measure the four-chamber view as well as the measurements of ventricular size, shape, and contractility using speckle tracking analysis using the engine from TomTech. The total integrated process to make measurements and review a comprehensive report takes less than 4 minutes. The Fetal HQ program allows for the importation of DICOM clips from Trisify and Viewpoint and also allows importation of clips from other GE machines using the 4D view format. In addition, the output from the analysis contains graphs, a printed report, a PDF of the report that can be exported to Trisify and Viewpoint. In addition, a CSV file with all the data can be exported for research evaluation. An important point I want to emphasize is that I received no compensation from TomTech or GE for doing this project and have paid for the TomTech software and upgrades to the E10 Voluson system used in my practice. Therefore, I am happy to report that the time required to do the research, write the papers, and see our efforts become a diagnostic tool of the Fetal HQ was all time donated by myself and my colleagues because we felt that this could change how we evaluate the fetal heart and other clinical outcomes. This illustrates the various components that interact to maintain adequate cardiac output. However, when there are changes in preload and afterload, alterations in heart rate, chamber size, chamber shape, and the contractility may occur. The question we should pose is, what should be evaluated in the fetal heart? In this presentation, I will share with you a new approach to evaluate the fetal heart using speckle tracking analysis. The measurements of the heart that would be important to consider would be first the shape and size of the four-chamber view, followed by the shape, size, and contractility of the ventricles. Let's now examine measurements of the shape of the four-chamber view. The shape of the four-chamber view can be computed by identifying the end diastolic frame. Two measurements are made. The first is the basal apical length in red, and the second, the transverse width in blue. The term used to describe the shape of the four-chamber view is the global sphericity index, or the GSI, which is computed by dividing the length by the width measurement. The mean value of 1.2 with a standard deviation of 0.09. The fifth centile is 1.08. Any value less than 1.08 is considered to be a round or globular-shaped heart. After evaluating the shape of the four-chamber view, the next step is to examine its size. An increased size, known as cardiomegaly, has a long list of associated fetal problems. This includes structural malformations of the heart, arrhythmias, abnormalities of peripheral vessels, and other fetal diseases. This is from a paper entitled Fetal Heart Size, a comparison between point-to-point trace and automated ellipse methods between 20 and 40 weeks gestation. To measure the size of the four-chamber view, we selected the end diastolic area and circumference using either the point-to-point trace or the ellipse tool on the ultrasound machine or using an offline software program, which is part of a DICOM viewer. From these equations, a z-score value and its corresponding centile can be computed for the individual fetuses at risk for an increased area or circumference of the four-chamber view. This is computed by subtracting the expected mean value derived from the above equations from the measured value from the at-risk fetus. The value is then divided by the standard deviation, derived from the above equations from the control group. Computation of z-score values was used in many publications that I will discuss in this presentation. These are the corresponding graphs for the area using the estimated fetal weight. Note that the graphs for the area and circumference comparing the two methods are almost identical. We also provide an Excel calculator for ease of computation. This is a comparison of graphs from our study and a recently published study from the Barcelona group. Note how similar the graphs are. Once the four-chamber view, size, and shape have been analyzed, the next step involves measuring the shape, size, and contractility of the right and left ventricles. However, let's ask the following question. What would be the characteristics of the ideal measurement tool to evaluate the right and left ventricles? First, it would be to measure the size, shape, and contractility of the ventricles. Second, it would simultaneously make all of the above measurements. Third, it would be angle independent of the position of the four-chamber view in relation to the ultrasound beam. Fourth, it would provide results of the actual measurements, z-scores and centiles using different independent variables of fetal biometry and gestational age. Fifth, it would take less than 4 minutes to do. Speckle tracking analysis meets all of the previous criteria. Let's now explore this new diagnostic tool developed for this use. What is speckle tracking analysis? The endocardium of each ventricle is composed of digital speckles. The image on the left illustrates a portion of the endocardium of the ventricular septum, which has speckles of various shades of gray and intensity, represented by the green box. These speckles, located at different locations along the endocardial border, can be tracked by computer software as the ventricles contract. Point 26 is opposite point 24 at the apex of the septal wall, and point 49 at the base of the septal wall is opposite point 1 of the lateral wall. Data from the locations of these points from each slide of the chamber are used for the computations of the width of 24 segments, distributed from the base to the apex of the ventricle and the length. Using the right ventricle as an example, the user simply places the cursor at the base of the ventricle, points 1 and 2, and at the apex, point 3. This then activates the TomTex software analysis to compute the endocardial border at end systole and end diastole. Once the yellow lines identify the contour of the endocardium, the user can adjust each point of the contour as needed. Once the computation is completed, the display appears on the screen. Let's examine each of the components of the screen display. The upper left contains a clip of the four-chamber view and the endocardial tracing resulting from the TomTex analysis. The movement of the 24 segments in systole is displayed. The green line represents the end diastole and the yellow line end systole. The red lines demonstrate the movement of the 24 segments on the lateral and septal walls. This contains a summary of basic measurements which include the fractional area change, global strain, ejection fraction of the left ventricle, the area, length, and diameters of the ventricles. The measurements do not include z-scores or percentiles of the measurements. This is a graphical display of the right and left global strains and areas during a single cardiac cycle. Although the measurements are useful, the question that can be posed is the following. Are there additional measurements derived from the analysis of the raw data that may be helpful? The TomTex analysis provides the user the option to obtain additional measurements that are not on the main screen of the program. Let's examine the initial research data output in a text file from the TomTex software and see how this is done. This is the data output for the left ventricle. The data consists of several thousand X and Y coordinates representing the movement of the 48 equidistant points of the endocardium for one cardiac cycle as previously described. From the text file output, the data is imported to an Excel spreadsheet from which all of the measurements which I will describe are derived from the X and Y coordinates of the endocardial borders and are the basis for our publications. Let's now examine the specific measurements derived from speckle tracking analysis, many of which have not been reported until we published our studies. This is a new concept, the 24-segment end diastolic and end systolic widths of the right and left ventricles. The graphic on the right illustrates 24 segments, with segment 1 at the base, segment 12 located in the midsection of the ventricle, and segment 24 located at the apex. In addition, the length of each chamber can be computed. These end diastolic and end systolic measurements form the basis for a number of derived measurements that will now be discussed. Measuring the size of the ventricles. In this paper entitled Evaluation of the Right and Left Ventricles, an Integrated Approach Measuring the Area, Length, and Width of the Chambers in Normal Fetuses, we measured the end diastolic length, width of segments 1 and 12, and the area of each ventricle. While these measurements were obtained using speckle tracking analysis, they have also been reported using other online and offline methods. This is a comparison of graphs from our study and a recently published study from the Barcelona group. Noted how similar the graphs are for ventricular length. The ventricular width at the midsection is similar for the LV, but there is a difference for the right ventricle at the 95th percentile line. The ventricular area has a wider distribution for the 5th and 95th centiles. This study was entitled Comprehensive Evaluation of Fetal Cardiac Ventricular Widths and Ratios Using a 24-Segment Speckle Tracking Technique. The 24-segment RV-LV ratio did not correlate with gestational age or fetal biometry of the head, abdomen, or femur. The next set of measurements involves computing the shape of the ventricles from the 24-segment sphericity index. This is computed by dividing the length of each ventricle by each of the 24-segment widths to measure the sphericity index at end diastole. These measurements allow the examiner to quantify the shape of the ventricle. Lower sphericity index values being associated with a globular-shaped chamber and a higher value with a more flattened chamber. The title of this paper, Right and Left Ventricular 24-Segment Sphericity Index is Abnormal and Small for Gestational Age Fetuses, illustrates the importance of the 24-segment analysis of ventricular shape. In the study of small for gestational age fetuses, previous studies had only evaluated the sphericity index for segment 1 of the right ventricle, located at the base of the chamber. If we only examined segment 1, 23% of fetuses would be identified to have an abnormal sphericity index. However, if we examine 24 segments, 40% would have an abnormal sphericity index. The same finding was also observed for the left ventricle. If we only examine segment 1, 33% of fetuses would be identified to have an abnormal sphericity index. However, if we examine all 24 segments, 53% would have an abnormal sphericity index. These diagrams illustrate the three types of measurements of contractility we can evaluate using speckle tracking analysis: global, transverse, and longitudinal. Let's examine each one of these in detail. Global contractility examines the effect of transverse and longitudinal contractility on the entire ventricle. This is accomplished by measuring the fractional area change, or FAC. The areas for the right and left ventricles are computed for end diastole and end systole. Once the areas are measured, the equation for computing the fractional area change is simply the end diastolic area minus the end systolic area divided by the end diastolic area and multiplied by 100. The higher the value, the better the global contractility. The next measurement of ventricular function we computed from speckle tracking analysis was the 24-segment transverse contractility or fractional shortening. The 24-segment widths were measured at end systole and end diastole. The real-time image illustrates movement of the ventricular and septal walls from a sample of 6 segments. Notice how the yellow dots move in the clip. Septal and lateral wall movement for the LV have a movement towards the center of the chamber as manifest by the yellow dots in the graphic on the right. However, there is less movement of the septal wall for the right ventricle towards the center of the chamber compared to the left ventricle. This represents the 24-segment fractional shortening values for the right and left ventricles. Notice that the mean blue line for the right ventricle is constant from the base, represented on the left by segments 1 to 8, to the apical segments, represented by segments 18 to 24. This is because most of the transverse movement is from the lateral wall of the right ventricle, as demonstrated in the graphic, and not on the septal wall. The left ventricle, represented by the red line, however, has a higher mean value compared to the right ventricle from segments 7 to 24. This is because of the contribution of the inward movement of the interventricular septum. Let's now examine a case of a hypoplastic left ventricle. In this example, the left ventricular wall moves either away from the center of the chamber at the base or does not move at all in the midsection. This results in decreased fractional shortening. This is a case of critical aortic stenosis. Notice how the septum of the left ventricle moves away from the center of the left ventricle, resulting in a markedly depressed fractional shortening. Let's now examine the first of 4 methods to measure longitudinal contractility, which represents movement of the base of the heart towards the apex. Traditionally, this has been done using M-mode ultrasound, in which the cursor is placed in the lateral wall perpendicular to the annulus. The excursion of the annulus is then measured. Abnormal values are present when the annular movement is less than expected. Now let's examine the use of speckle tracking to measure the same annular movement as the M-mode. This is called the basolateral and septal wall annular plane systolic excursion. The distances from the apex to the base, represented by the blue lines at end diastole, are measured, as well as the distances represented by the red lines at end systole. The difference between the two is called the annular plane systolic excursion. This can be measured for both the lateral and septal walls of the right and left ventricles. These graphs represent the mean 5th and 95th centiles for the left ventricular lateral and septal walls, and the lateral and septal walls for the right ventricle. Notice the lateral wall excursion is greater than the septal wall excursion. When we compare the right ventricular lateral wall with the left ventricular lateral wall, the right ventricular annulus moves further towards the apex of the left ventricle. However, there are no differences between the ventricles for the septal wall annular movement. A second measurement of longitudinal contractility is called the longitudinal annular systolic displacement fractional shortening, in which the center of each ventricular chamber is identified, and their corresponding lengths are measured at end diastole and end systole. This measurement is computed by subtracting the systolic length in red from the diastolic length in blue and dividing the value by the diastolic length multiplied by 100. A fourth measurement of longitudinal contractility is called global longitudinal strain. This is measured by computing the length of the endocardium at end diastole, represented by the blue lines, and the length of the endocardium at end systole, represented by the red lines. The cardiologists have computed global strain by subtracting the end diastolic length from the end systolic length and dividing the value by the end diastolic length. This gives a negative value because the diastolic length is longer than the systolic length. The more negative the global strain value, the better the contractility. For example, a minus 27 is better than a minus 13. This is a list of studies that measure left ventricular strain. We compared our mean values with our data and found the results from the studies highlighted in red were within our normal range. This is a list of studies that measured right ventricular strain. We compared their mean values with our data and found the results from the studies highlighted in red were within our normal range. Finally, we measured left ventricular function. The useful measurements that can be derived are the end diastolic and end systolic volumes, stroke volume per kilogram, cardiac output per kilogram, and the ejection fraction. Traditionally, cardiac output has been computed for both the right and left ventricles by measuring the diameters of the aorta and pulmonary artery as represented in images A and B, followed by pulse Doppler measurements of the velocity time integral. From this, the cardiac output has been computed. One of the problems with using the measurements of the aortic and pulmonary outflow tracts and the velocity time integral is a large error that can be potentiated when measurements of the diameter are not accurate. This example, we see that the diameter of the aorta of 0.46 centimeters is the normal measurement, and just a slight adjustment just beyond the boundary to 0.6 centimeters changes the cardiac output from 324 to 536. The graph on the right illustrates this point. Therefore, one has to be very precise in measuring the outflow tracts when computing cardiac output using the Doppler method. Let's now examine the clinical application of the analysis of the measurement tools I have just described. The first study I would like to discuss has recently been published, in which 50 fetuses with an estimated fetal weight less than the 10th centile were examined. The two papers that were published were entitled Size and Shape of the Four-Chamber View of the Fetal Heart in Fetuses with an Estimated Fetal Weight Less than the 10th Centile. And the second paper, Assessment of Ventricular Contractility in Fetuses with an Estimated Fetal Weight Less than the 10th Percentile. Both of these papers originally were in press and now have been published in the American Journal of Obstetrics and Gynecology. We use the definitions of fetal growth restriction published in 2016 in the Journal of Ultrasound Obstetrics and Gynecology. The classification of fetuses with an estimated weight below the 10th percentile are as follows. If the estimated fetal weight was less than the 3rd centile, that was defined as fetal growth restriction. If the estimated fetal weight was between the 3rd and 10th percentile, and the Doppler of the umbilical artery and cerebral placental ratio were normal, that was considered a small for gestational age fetus. However, if either of these Dopplers were abnormal, then the fetus was classified as growth restricted. This is the Delphi classification. Our study was divided into two groups. Group 1 had an estimated fetal weight less than 10th centile, but had normal Doppler studies of the umbilical artery and a normal cerebral placental ratio. These fetuses were labeled small for gestational age. Many investigators have thought these fetuses were not at risk for adverse outcome. In the first study, we asked the question, is there a screening test that would identify fetuses with an estimated fetal weight less than the 10th centile who would be at risk for cardiac dysfunction? In the first study, we asked the question, is there a screening test that would identify fetuses with an estimated fetal weight less than the 10th centile who would be at increased risk for cardiac dysfunction? Of the 50 fetuses, irrespective of their Doppler findings, 86% had one or more of the following end diastolic abnormalities of the four-chamber view: increased width, increased area, decreased global sphericity index. Of interest, 86% had abnormal ventricular contractility using speckle tracking analysis. When we looked at the 25 fetuses with an abnormal Doppler of the umbilical artery or CPR, 92% had one or more of the following abnormalities of the four-chamber view: increased width, increased area, or decreased global sphericity index. Of these fetuses, 97% had abnormal ventricular contractility using speckle tracking analysis. When we examined the 25 fetuses who were SGA, that is, a weight below the 10th percentile, but had a normal umbilical artery or CPR, 80% had one or more of the following end-diastolic abnormalities of the four-chamber view: an increased width, increased area, and decreased global sphericity index, of which 85% had abnormal ventricular contractility using speckle tracking analysis. If we look at the overall cardiac function in these fetuses, what's interesting is the SGA fetuses, as represented by the red box, 40% had an abnormal global contractility of the right or left ventricle. If we look at the transverse contractility in the SGA fetuses, 68% had an abnormal right ventricular contractility and 39% left ventricular contractility. If we examine longitudinal contractility in the SGA fetuses, 45% had an abnormal right ventricular longitudinal contractility and 36% for the left ventricle. The conclusions from the study were as follows. With an estimated fetal weight less than the 10th centile, of course, the IUGR is defined and identified. However, fetuses that had an estimated weight below the 10th percentile and normal Doppler studies, fetal cardiovascular dysfunction was present in these small for gestational age fetuses, and as well as cardiac function being abnormal in fetuses with growth restriction. In a study by Gerson et al., they did not find abnormal cardiac function for fetuses with an estimated fetal weight less than the 10th centile and normal Doppler of the umbilical artery and cerebral placental ratio. However, they found that the atrial natriuretic peptide was significantly higher in these fetuses. In this same group of fetuses, we found 84% to have a combination of abnormal global, transverse, and longitudinal contractility for one or both ventricles. Therefore, we feel that the assessment using speckle tracking analysis in these fetuses was superior to the traditional methods used for fetal evaluation of cardiac function. Now let's examine the fetuses with growth restriction who had absent or reverse umbilical artery Doppler flow. This is a paper recently in press. It's entitled Cardiac Measurements of Size and Shape in Fetuses with Absent or Reverse End-Diastolic Velocity of the Umbilical Artery and Perinatal Survival and Severe Growth Restriction before 34 weeks gestation. In this study, we identified 53 fetuses who had absent or reverse end-diastolic flow of the umbilical artery. In this group, there were 16 perinatal deaths and 37 that were born alive. If we look at the four-chamber view and the percent of fetuses with abnormalities, there are no significant differences in the area of the four-chamber view greater than the 95th centile, the width greater than the 95th centile, the length greater than the 95th centile, or GSI below the 5th percentile for those with the perinatal death or those who survived the neonatal period. There are no significant differences between these groups as well for the 24-segment transverse widths greater than the 95th percentile, as you can see for segments 1 to 8, 9 to 16, and 17 to 24. The ventricular wall thickness also demonstrated no difference between the two groups when it was above the 95th percentile. Both the right and left ventricular walls were examined. However, the ventricular area less than the 5th centile, this was only present in fetuses who were alive. Perinatal deaths did not have ventricular areas less than the 5th centile. If we look at left ventricular 24-segment transverse widths less than the 5th centile, only those who did not have a perinatal death had values below the 5th centile. If we examine left ventricular 24-segment transverse widths above the 95th percentile, the alive group did not have widths above the 95th percentile. only those with perinatal deaths. If we examine a fractional shortening of the left ventricle, you see, for example, looking at the actual values for the base, mid, and apical sections, those are alive are represented by the blue, and those who died in the perinatal period are represented by the red. All values below the 10th percentile, most of them below the 5th percentile. This occurred in 81% of fetuses who suffered a perinatal death. If we compare the Z-scores between the two groups, we see the left ventricular ejection fraction was markedly decreased with a Z-score of minus 5.6 and occurred in 81% of fetuses compared to those who were born alive at a Z-score of minus 1.68, which is around the 5th percentile. 94% of these fetuses had one or both abnormal functions of the left ventricle. Again, if you look at the Z-score for the ejection fraction was markedly depressed in those with the perinatal death, as was the 24-segment fractional shortening. If we look at fractional shortening of the right ventricle, again, it was markedly depressed for the base and mid sections in those who had a perinatal death versus those who were born alive. Conclusions. Cardiomegaly is common for both groups of fetuses. 2, ventricular wall thickness is common for both groups of fetuses. 3, a smaller left ventricular area is present in those who did not have a perinatal death. 4, a larger left ventricle is present in fetuses who had a perinatal death. 5, abnormal left ventricular contractility was present in fetuses with perinatal deaths, as represented by the following: decreased LV ejection fraction, decreased LV fractional area change, and decreased 24-segment fractional shortening. Let's now examine coarctation of the aorta. This study, entitled Aortic Coarctation, a comprehensive analysis of shape and size and contractility of the fetal heart, examined the 4-chamber view in the right and left ventricles as previously described. We found that the 4-chamber view was more globular in 31%, wider in 24%, and had an increased area in 22%. Evaluation of the 24 segment sphericity index of the left ventricle demonstrated that all segments were significantly greater than 95th centile, suggesting flattening of the left ventricle. Evaluation of the 24 segment sphericity index of the right ventricle demonstrated that all segments were significantly less than the 5th percentile, suggesting a round or globular shaped ventricle. Evaluation of the area of the ventricles demonstrated that the left ventricle was small in 86% of fetuses and the right larger in 30% of fetuses. Decreased fractional area change was decreased below the 5th centile in 52% for the left ventricle and 40% for the right ventricle. Abnormal 24-segment fractional shortening was present in 40 to 51% of fetuses for the left ventricle and between 22 and 45% for the right ventricle. Knowing the cardiovascular profile of the heart in fetuses with coarctation of the aorta, as we just described, we propose the question: how can we predict which fetuses will have neonatal coarctation of the aorta from those who will not? Logistic regression analysis was done for the 108 fetuses to identify which measurements represented in this slide would correctly separate the true positives from the false positive fetuses. While all fetuses were suspected to have coarctation of the aorta prenatally by a pediatric cardiologist, the above classification identified 54 with coarctation and 54 without coarctation postnatally. This study therefore had a cohort with a 50% false positive rate. This represents the associated cardiac anomalies seen in the coarc and false positive coarc fetuses. Both groups had additional cardiac findings, with the coarc group having more than the false positive group. Using logistic regression analysis, 28 variables were identified that included the size of the 4-chamber view, the size and shape of the right and left ventricles, and abnormal contractility of the right and left ventricles. The Z-score for each of the above measurements from each fetus was multiplied by the respective coefficients from the logistic regression equation. The values were summed and the probability of coarctation computed. The analysis correctly identified 96% of the fetuses who had neonatal coarctation with a false positive rate of 4%. The specificity was 96% with a false negative rate of 4%. The area under the ROC curve was 0.98. In conclusion, I would like to change the quote from T.S. Eliot to the following: "We shall not cease from exploration, and the end of all of our exploring of the 4-chamber view will be to arrive where we started and know the place for the first time."
Thank you very much to Gregory DeVore for this very comprehensive presentation, especially speaking about the speckle tracking analysis, is already connected with us. I'm very happy that he will participate to the discussion. Please, those who are attending, start asking your question in question and answer box. In the meantime, I would like to introduce the co-chair, Professor Giuseppe Rizzo, to give the last presentation of this first part of the course. Professor Rizzo is a professor chairman of the Department of Aesthetic and Ecology at the Second University of Rome. Tor Vergata has been a president of the Italian Society of Ultrasound and Aesthetic and Ecology, and he bears now multiple diplomas and society membership and presidentship, and is undisputed expert in the area of fetal cardiology. Giuseppe, thank you to be with us, and your talk is remodeling of the fetal heart, taking consideration the IGR, gestational diabetes, and also the assisted reproductive pregnancy.
Thank you very much, Giancarlo, for your kind words. It's very pleasure for me to be here and to speak in this important session. When we speak as a perinatologist to the heart disease, we are mainly worried about the possibility to have or misdiagnosis a congenital heart disease. In reality, most of the disease are acquired, and the cardiovascular disease, at least in Europe, account of approximately 1/4 of all the disease and account every year of 4 million of deaths. So it is really important. Why to speak of cardiovascular disease during fetal heart? This was something that it was already postulated in 19 by an epidemiologist, Professor Barker, who believed that different conditions occurring during intrauterine life, including some maternal nutritional deficit, the overlapping of some obstetrical complications such as preeclampsia or gestational diabetes, and the exposure to pollution or to other toxic substances like tobacco and alcohol may induce a placental dysfunction that can, of course, affect the fetal heart of the baby. And the consequence to this abnormal fetal environment, the newborn may develop a low birth weight, but also a sequelae during his adult life or cardiovascular disease. If you think about the fetal heart, the mechanisms are different, from which the fetus react to an insult, maybe hypoxia, maybe one of the diseases that we discussed before. And essentially, and as we have already heard by the previous speaker, the heart can change in remodeling, redistribution, dysfunction, and the aim of this change is to try to keep an adequate blood supply to organs, particularly the brain and the heart itself. These are some examples. We have seen the lecture, on cardiac dysfunction, and we have seen how several parameters of systolic and diastolic function can evidence fetal deterioration. We have known that the intrauterine growth restriction is an excellent model, the model of redistribution, in which there is a change in the ratio between the left and right cardiac output. But one of the other possibilities in which the fetal heart reacts to an insult is changes its shape. These are two examples. This is a typical case of an hypertrophic heart, for example, of fetus of diabetic mother with poor level of compensation. Or we can change its shape, becoming more globular, as very elegantly showed you before, Professor De Boer. Which are the clinical conditions in which this change can occur? Of course, fetal growth restriction, both in the early and late form. The fetus of diabetic mother, both with pre-gestational diabetes and gestational diabetes. And more recently, it was appeared that despite a normal growth, some change may occur also in fetus coming from in vitro fertilization, with some difference if they are conceived by egg donation or by the eggs of the mother, and also according to the type of the procedure which was used, if the embryo are fresh or frozen thawed. Looking at the fetal growth restriction, this is the easier and more extensive study model. A fetal growth restriction fetus is defined as a fetus which failed to achieve its own growth potential. And according to the Delphi definition, they are clearly divided into groups. One which is early, which is the more severe, in which the particular definition is given by the time of diagnosis, which is before 32 weeks of gestation, and one which are latent, which is the diagnosis is performed later. What we know about the cardiac hemodynamic of the fetal with early gestation? A lot. Essentially, these fetuses are small, as characterized by definition by the small abdominal circumference, have increased impedance to flow at the level of the umbilical arteries. This is a typical example of absent and diastolic flow, suggesting high impedance to flow in the placenta. And on the contrary, at the level of the brain, there is a massive cerebral vasodilation doing a decrease in middle cerebral PI. This, of course, affects the cardiac afterload, the afterload of the right ventricle, which is faced to the peripheral circulation, mainly to umbilical, placental and splanchnic circulation is dramatically increased, while the impedance to flow at the level of the right ventricle is decreased, since the left ventricle is faced to the coronary artery and to the cerebral circulation. As a consequence, there is a shift in the output between left and right cardiac output. I want to thank Professor De Boer to show also his, in his presentation, this slide. This very old paper, 30 years ago, when I am a young researcher, but it was an important topic of research, in my opinion. We first demonstrated that in the small baby, there is this kind of redistribution of the fetal heart. We also know that after the redistribution is happening, there is a progressive deterioration in systolic and diastolic function, resulting in an abnormality of the venous circulation, and the ductus venosus is the probably easiest way to use. And now the timing of delivery of this early growth restricted baby is based mainly on the computerized CTG and the study of the ductus venosus, as very well shown by Traffer-1 study. More complex is the situation of late FGR, fetus who are diagnosed later and in the past considered as a benign condition. In reality, more deeper studies have shown that also these fetus may have short-term and long-term sequelae, particularly of the higher risk of developing cardiovascular disease in adult life. This is, for example, a study from the Barcelona group showing how the neurodevelopment outcome in born with late fetal growth restriction is poorer than in the control. The diagnosis of late fetal growth restriction is principally based by the diagnosis of a small fetus and abdominal circumference below 1/3 of 10 centile according to the criteria, and of course associated with the Doppler parameters. As you can see, the pathophysiology is different in this condition. Again, we have small fetuses, but usually the blood flow in the umbilical artery is absolutely normal, while there is a massive reduction of the impedance to flow in the cerebral artery. As a consequence, we have no change in the afterload of the right ventricle, while there is a decrease according to the severity of the cerebral vasodilation at the level of the left ventricle. What happens to the cardiac output of this late growth restricted fetus? This is our data showing that there are no significant difference in the ratio irrespective of the early form, and also correcting the absolute value of the left and right cardiac output for the fetal weight, there are no significant change. What we know from the data, particularly of the group from Barcelona, that despite no absolute change in the cardiac output, there are changes in the shape of the heart. And in particular, the typical phenotype of the late fetal growth restriction is an heart which is more globular, characterized by a relatively low ratio between the ventricular length and the ventricular length. This is an example. You see a 4-chamber view as shown Professor DeVos. As you can see, also without any kind of sophisticated software, it is possible to evaluate the ventricular width at the level of the atrioventricular valve and the ventricular length at the level of that ventricle, and evaluate a very simple index which is called sphericity index. We evaluated the significance of these findings in a population with late fetal growth restriction, and these are the results. You can see that among a population of late fetal growth restriction, those showing an abnormal sphericity index of the left ventricle, there is a higher incidence of fetal distress, a lower pH in the umbilical artery at birth, and higher incidence of the admission to a special care unit. The question is, what can induce this change? Is a question of reduction of oxygen, is a question of loading condition. And we try to evaluate our data, and we see that if we analyze the relationship between the abnormal sphericity index in the left ventricle and the result of the umbilical artery PI, middle cerebral artery PI, and CPR, we found that there are no difference between the two groups, thus suggesting that there are no significant change in the afterload that may explain the change in the fetal heart shape. On the other hand, we know from the literature, this is a very nice study obtained with magnetic resonance, in which we found the hemodynamic change occurring in fetus with late growth restriction. And they found that in particular, in fetus with late growth restriction, there is a significant decrease of the umbilical vein flow, which is one of the most significant parameters. So suggesting that in this fetus may be a reduction in the preloading, the blood that come back to the heart. In order to verify this hypothesis, we performed a technique to evaluate the umbilical vein flow. We constructed reference limits, and we evaluate whether there are any relationship between the reduction of the umbilical vein flow present in such fetus and the subsequent cardiac function. And you can see the results. You can see how, according to the severity of reduction of the umbilical vein flow, higher is the prevalence of abnormal left sphericity, suggesting that a reduced umbilical vein flow is probably one of the variable, more important variable in explaining the change in the fetal heart. Second aspect is diabetes. We know that the incidence of diabetes is dramatically increased. These are the estimate at 245, which most of the population will be diabetic. And we know also that actually estimate that in all the world, one pregnancy of 6 is complicated by diabetes, and most of this pregnancy, of this diabetes, it starts during pregnancy, and the prevalence of gestational diabetes is 80%. We know that one of the important things in gestational diabetes is that placenta seems bigger and there is a higher vascularization. And probably this increased vascular placenta vascularization may increase umbilical flow and induce change in the cardiac function. We recently performed this study in the first trimester. We evaluated the umbilical blood flow, and we evaluated the risk to developing later in third trimester of a baby which is LGA or diciamo macrosomic. And you can see how the evaluation of the umbilical vein already in first trimester allows us to predict the insurgence of a big baby, both macrosomic or LGA. There are several changes induced by maternal hyperglycemia. They are described very well in literature by us and others. And we try to see if there are some changes also in the cardiac remodeling in fetuses of mother with gestational diabetes. We have these two groups divided according to the quality of the control. Again, we evaluated the sphericity index in the two ventricles. And you can see there are some changes, less evident that in growth-restricted baby, but over interest they became significant when gestational diabetes reached the poor control. The final question is mode of conception can affect the function of the fetal heart. We know that the number of IVF pregnancy is increasing, and we try to evaluate the effect of this condition by comparing three different groups of fetus. One is a control group, one are IVF pregnancy from frozen embryo, and one are IVF pregnancy from fresh embryo. I apologize, this slide is a little fuzzy, but the message that again there are changes, and these changes are more evident in embryo with fresh transfer, suggesting that under this condition the quality of the endometrium is poorer, the placenta is working less, and this induces this change. This is better. Okay, you can see how the change in the sphericity index are significant in both groups from in vitro fertilization, and how the worst results are present in fresh embryo. Sometimes it be that the two conditions are superimposed. This is a paper from Ilya Mappa, who show how in women coming from in vitro fertilization, but have also concomitant fetal growth restriction, the pattern was mixed and the phenotype of fetal growth restriction is more evident. Of course, these are extremely nice, interesting data. Of course, we have to look at the postnatal effects, both in the newborn and in the young adult. We know from some follow-up data from Spain that this change in cardiac remodeling, at least in fetal growth restricted baby, persists also later in age. This is, for example, data from adolescent. You can see how different the heart in a baby which was born of normal weight of fetal growth restriction. What's about the potential treatment? I think this will be the future. You see, for example, this study in which showing that if the mother performs artificial feeding, there is a little recovery. If the mother performs breastfeeding for at least 1 month, there is the best recovery. And the best situation is the mother that have breastfeeding at least of 6 months with a particularly diet, a Mediterranean diet. So in conclusion, we think that we have understand that cardiac remodeling is obtained in different conditions, at least fetal growth restriction, fetal maternal diabetes, and IVF. How we can try to prevent prenatally in the fetal growth restriction model, of course, try to optimize the time of delivery. In the diabetes, try to control the glycemia, since we see that the worst results are in hyperglycemic women. and in the IVF patient, probably selecting the technique that avoid the use of fresh embryo. Postnatally, of course, breastfeeding seems to be extremely important, and of course, an adequate postnatal diet. The future probably is to move this postnatal diet also in the prenatal life, and Professor Di Renzo is studying already a format of a correct nutrition of the mother, not only when they are pregnant, but also when they are becoming pregnant. And is my own opinion that will be the future for the best assistance to these women. Thank you very much for your attention.
Thank you very much, Giuseppe. Very clear and also with very important clinical messages taken from this most frequent situation, pathological situation in pregnancy. I think that we have finished our formal presentation. We have all connected the speakers. Also, Professor Gregory DeVore is with us from far away California. And we can interact either with the question directly between us or looking at the question and answer from our attendants. So, Giuseppe, if you want to start with some question, or if you read a question from the question and answer, you can address to all the panel, all those from the panel who feel to be more involved, or at least they can give an answer to the different question, okay?
Yes, thank you, Giancarlo. And I think you have a very stimulating afternoon or morning. There is a question from the people attending, from Gustavo. I don't know if he's connected or not.
Yeah, it's connected.
It's connected.
Yes.
Asking about the quality necessary to perform this kind of manipulation of the cardiac volume. I think this is a real problem, because for this, something of real exciting, stick is very exciting, but most of the time the quality is poor, and from poor image, usually it's very difficult to obtain better image by 4D.
Gustavo, yes, okay, you can answer.
Sorry, I'm back.
No, the question was for you. Did you get the question?
I answered one question. Let me see if this is a different one.
No. It's a question raised by Professor Rizzo about the poor quality and which fits. Can you summarize, Giuseppe?
Yes. I can explain that. Ultrasound is a modality that is affected by several factors. That the poor quality is the expression of those factors. For is fetal positioning, the BMI, and ultrasound, and therefore 5D heart is not excluded from those problems. So some problems can be managed. For example, the fetal presentation or the motion artifact, the duration of the acquisition. 5D heart has some resources to manage that, okay? So to cope with those problems. But if the image, let's say that the image is a very, very bad BMI, so even in 2D you're not getting a good image. The beauty of our method is that because the marking of the points are not related to image recognition, as long as those spots, those landmarks are properly marked, the slicing will be adequate. The image quality may not be great, but still the dissection is proper. So the conclusion is that 5D heart will not improve the image quality of the baby, but may get the right section that we are seeking.
Can I make a comment about that?
Yes.
One thing, stick with
how are you, Professor DeVore?
I had surgery 4 days ago, so I'm in a sling. I had a rotator cuff. So that's why I look kind of funny. I'm not in my office. I'm at home recovering. One thing that's important when we introduced stick many years ago, of course, We know in the B and the C planes, we get sometimes artifact because of movement.
Yeah.
One of the improvements of the electronic stick probe, which is of course very expensive,
Yeah.
is that it acquires subvolumes and stitches them together. So there's less artifact in the B and the C plane. So if one, for example, wanted to take and collect a series of volumes, and you had the electronic stick probe, that's ideal because you'll have less artifact. And for example, in the second trimester, you may have almost a perfect B and C plane because the subvolume almost encompasses the entirety of the heart. So that's something to consider if you're collecting stick volumes for this type of application. The electronic probe really adds a lot of advantages because you have subvolumes which are perfect versus multiple slices that are stitched together that have artifact.
Can I mention? I totally agree with your position about that. So we did an improvement like 3 years ago. That is, we added another method of acquisition that we call like a fast acquisition. So this is a 1 second sweep, just 1 second. Of course, no beating heart, no beating heart. But what is interesting, Professor DeVore, of this is that 1 second acquisition in the C plane, in the B planes, have much higher resolution than a 10-second stick. So that's curious because we said, how come 1 second? Because 1 second is even faster than the EPRO. EPRO is 2.5 seconds. This is 1 second. It's 3 times less, almost. So yes, it doesn't beat. But if you want to see the long arches, if you want to see the cabal view, if you want to see the ductal arch or something like that, they may have a role. So depending on the situation, you can wait for a good stick. You can include in color if you are lucky. But then if you want just to check the arches, you do a quick sweep and that's enough. So I don't know. Maybe there are tricks that we can apply.
Well, I agree. I think that's an important point. I often have used the fast static sweep to grab the volume, and you can. I developed a technique called the spin technique years ago, where you put the dot.
Yes, I remember. Yes,
and you can see everything unfold. So that's another great option for the 3D, the quick static.
And you know what? It's like, let's say that this baby is not cooperating, the baby is moving crazy, and the mother is breathing, and everything is wrong. Okay, so you get this quick 1 second thing. You get what you can get, and then with the 2D, you go to the valves and you go to the dynamics. So maybe it's a hybrid solution. Okay, I don't know.
So if I can summarize for the people, I think I completely agree with the opinion of Gustavo and Gregory. Of course, there is an incredible advance in technology, and probably the 4D stick that we use in the past is not the same. The second important thing is my opinion that you have to go ahead with your examination and look for a moment of nice and favorable fetal position and quiet, and use these few seconds to acquire the plans that you need. I have a question for Valentina. Again, congratulations. My question is if you have to perform a score about all the index of cardiac function that you described. In your opinion, in a condition relatively stable for pathogens like fetal growth restriction, which will be the selection? So we use first, then second, third, and so on.
I mean, everything depends on the time, how much time you have, how much busy you are. If you have only 10-15 minutes for this patient, it's quite difficult to perform all advantages to calculate the scores, or even in this case of fetal growth restriction, I usually look at ductus venosus for sure, because ductus venosus show how a systole and diastole is very easy to perform. And I like to do a M regime because I can evaluate systole function and assess longitudinal motion. And ventricle flow not in any case can be so producible, but M regime, yes, I like mostly inductors.
Giuseppe, there is a question, I think, for Gregory. Gregory,
Yes,
recover soon, if I understand well, okay, but I see you well. Depending on decreasing ventricle function in fetal coarctation, would you indicate earlier delivery if it is a premature baby?
No, our study that I explained during my presentation, the real value of the coarctation is we had, like I think I said, 54 fetuses that had coarc and 54 that did not. These were all prenatally diagnosed by pediatric cardiologists who have had a lot of fetal experience. So they thought that they had coarc, so strong suspicion. And the value of going through the elaborate exercise with the analysis was that you're able to define those who truly had a coarc. And I think that's the value of it. So that, for example, let's say that somebody was concerned about whether they should be delivering in a tertiary center, then going through that exercise would allow them to take and further define what the triage would be.
Very good. Okay. Any other question, JP?
Yes, I have a question from Graziano. Do you think that this kind of automatic technology may help for people in training? Or do you feel that it's better that a person in training was first learn to obtain all the basic and advanced injection and then can move to this kind of automatic software?
I think it can be useful for training people also, because as Gustavo said, it is important to have this kind of tools for the examination of the patient independently of the position of the baby. But I think that can be useful also for understand the real morphology of the heart and to move the probe in order to get some ultrasound beam and some scanning plane. So the comparison between the automatic evaluation and to try to get this kind of session, automatic session, may be very useful for the learning purposes.
Good. I don't know if there is any other question, but I remind you that for those who are not, we didn't been able to connect because of far away with the time lag, this is recorded and maintained recorded for a week. And secondly, that you may go to the YouTube of some of our speakers, Lamier also, that is not present, but it was one who developed the fine, for instance, and you can find all this information. Also, Graziano Clerici has a YouTube channel and others as well. So, Jeppy, do you have any other question for our speaker? So I think that we are almost on time for closing because it's practically 6:20 European time, 12:20 Central America, and maybe a little bit early for Gregory. I would like to thank, if you allow me, on behalf of the Preis School and the Wayne State University to participate in this very interesting course. And also I invite you to continue with the second part, will be Wednesday, and there will be also a simulation course for the next Monday, so Monday, October 3. Thanks to our excellent speaker, and we'll be in contact. I think this kind of courses are very helpful to ameliorate our, capabilities to investigate this very difficult organ, which is the fetal heart rate. Thank you very much to everybody, particularly to my co-chair, Professor Rizzo, and to the speaker participants. JP, what you say something?
Yes, just have a nice evening, afternoon, or morning. It was really a pleasure to be with you. I think together with Preis School if you have any kind of further question for any kind of rediscussion of the topics discussed, or also for some training program. I think you have to refer to Giancarlo Di Renzo, who is extremely in these topics. And thank you very much for everything. Goodbye.
Thank you. Bye-bye to everybody. We can close. Bye-bye. Thank you, Gregory. Stay well. Gustavo, see you all Wednesday.
Thank you very
Ciao.
much.
Ciao to
Bye-bye.
everybody.